Good morning, everyone. My name is Karim Ben Salah. I'm a urologist working in Rennes, west of France, and I'm very happy to be with you at this virtual EIKCS. I thank the organizers for the invitation. I've been asked to discuss an interesting topic, which is the comparison of radical versus partial nephrectomy to treat CT1 renal masses. Do we need a randomized trial? So the first issue we have to look at is are the oncologic outcomes. And I will start by mentioning this Cochrane review that was published in 2018, and they addressed this issue of partial versus radical nephrectomy to treat small renal masses. They gathered a total of 138 studies, and in these studies, they only included one that was considered of sufficient quality. All the other studies were excluded because they were considered to have a wrong study design. So that's a first point, that the quality of the literature is quite poor. We mostly have retrospective cohort studies. So from these studies, what we can say is that partial nephrectomy is at least non-inferior to radical nephrectomy. As you can see in this recent meta-analysis that was published in European Urology, there was even a benefit in terms of cancer-specific mortality for partial nephrectomy. So as I said, we only have one randomized trials that was published by the EORTC in 2011. And the results were quite surprising because there was a benefit of radical nephrectomy compared to partial nephrectomy in terms of overall survival. So there are many biases that limit the message of this trial. There were more than 500 patients included, but in 45 centers over a 10-year period. But still, the results were quite surprising for the urologic community. Another thing that has to be taken into account regarding oncologic outcome is that when you do a partial nephrectomy, you have a risk, a limited risk, but a risk of positive surgical margin that does not exist with a radical nephrectomy. And when you have a positive surgical margin, you have an increased risk of recurrence, as you can see in this large series published in 2011. However, it does not seem to have any impact on survival, even with a long-term follow-up. Nevertheless, we now operate more and more complex tumor and high-risk tumors, and it is unclear whether a positive cervical margin has any impact in that setting. The second issue we have to address is the occurrence of chronic kidney disease and the risk of mortality. All the studies go in the same direction. Partial nephrectomy clearly better preserves renal function than radical nephrectomy. There is a decreased decline in EGFR, and there is a decreased frequency of chronic kidney disease with partial nephrectomy. And as it was reported in 2004 in a famous publication in the New England Journal of Medicine, the EGFR and the alteration of EGFR is correlated with the risk of death. And because of this, many urologists have made the hypothesis that there was a benefit in overall survival of partial nephrectomy versus radical nephrectomy for tumors of the same stage. However, chronic kidney disease is not always the same. There is the chronic kidney disease that you have because of a cardiovascular condition, for example, which is termed medical chronic kidney disease. And there's the chronic kidney disease that you have because you have less nephron, as when you had a partial or radical nephrectomy. And these two conditions are not the same, as you can see on these curves that come from a very nice work from the Cleveland Clinic. When you have a surgical chronic kidney disease, the global survival is quite the same as when you don't have any renal impairments. So that might not be the same, and that should be considered when proposing a radical nephrectomy or a partial nephrectomy. This is another recent publication from the Mayo Clinic that goes in the same direction. They compared about 2,000 partial and radical nephrectomy and for CT1 renal masses, and they found that there was an increased risk of chronic kidney disease and decline in eGFR when you do a radical nephrectomy, but there was no difference in all-cause mortality. And finally, when you look at events that matter, such as cardiovascular events, hypertension, permanent hemodialysis, development of chronic kidney disease, in the Cochrane review that I mentioned at the beginning of my talk, the authors conclude that they did not find any evidence that any one of these outcomes was increased in frequency with radical nephrectomy. Finally, the last topic that we have to address is the morbidity. Partial nephrectomy is more morbid than radical nephrectomy. There are more complications, especially bleeding and urinary fistula. However, these complications usually occur quite early after the surgery and probably have a limited impact on long-term quality of life. And furthermore, surgery is improving, and now partial nephrectomy is done more and more with a robotic assistant worldwide. And as you can see in this recent meta-analysis published by a great robotic surgeon and his team, Dr. Gill from Los Angeles, robotic partial nephrectomy is associated with a much nicer profile regarding morbidity. There is less bleeding, there are less transfusion, less complication, less length of stay, and they suggest that there could even be a benefit in terms of recurrence and mortality. So yes, partial nephrectomy is more morbid, but with the improvements of minimally invasive surgery, this is less and less true. So, in 2020, when you look at the last recommendations, particularly those from the EAU, they strongly recommend to offer partial nephrectomy to patients with T1 tumors whenever possible. And so the question that we ask when we contemplate to do a randomized trial is, does better renal function preservation reduce mortality? And is the slight increase in terms of morbidity of partial nephrectomy, is it worth it? In my opinion, a randomized trial comparing radical nephrectomy and partial nephrectomy would take a very long time and would not necessarily answer the question. So in my opinion, it's not necessary, not worth it. I think that what we need are better tools to evaluate the morbidity and the evolution of the tumor in a single patient, so we know what treatment we can offer. It can be partial nephrectomy or radical nephrectomy, but it can also be surveillance or thermoablation. And such tools are already available. I just give you two examples. This is my last slide. On the left, this is a nomogram that's been published recently by a group that evaluates the risk of major complication after robotic partial nephrectomy based on 5 very simple preoperative outcomes: the tumor complexity, the performance status, the comorbidity index, the gender, and the hospital volume. And on the right, you have a very nice model published by the team from the Mayo Clinic with, you see this very simple variable that you can have before surgery to evaluate the renal function after partial nephrectomy or total nephrectomy. And I believe that this is with these very simple tools that we will be able to deliver a tailored approach because every patient and every tumor is different. So for now, let's rather focus on these efforts rather than implement a randomized trial. I thank you very much for for your attention and for coming into this session, and I'll let you go back to the rest of the meeting. Thank you.